Welcome to the e-learning module on WHO classification of non-epithelial tumors of ovary. In this section, I'll be telling about approach to sex-cord stromal tumor, in short SASTs. The objectives are to describe the approach to ovarian sex-cord stromal tumor and to know the role of IHC in the diagnosis of these tumors. So what are sex-cord stromal tumors? These are heterogeneous group of neoplasm which are derived from primitive sex cord or stromal cells. So what are sex cord cells? These include granulosa cells and Sertoli cells, whereas stromal cells include theca cells, fibroblasts, and Leydig cells. And the tumors which are derived from sex cord cells, they will have epithelial configuration. So granulosa and Sertoli cell tumors can show epithelial configuration, whereas tumors derived from the stromal cells like theca cells and Leydig cells will show cellular gonadal stromal pattern. These stromal or sex cord cells are known to produce hormone under physiological condition. So hormones will be estrogen, progesterone, androgen, and corticosteroids. So fraction of these tumors can present with hormone-mediated syndrome rather than primary tumor itself. So tumor derived from the ovarian cells, that includes granulosa and theca cells, they will present with estrogenic symptoms like endometrial hyperplasia, whereas tumors which are derived from the testicular cell types, example Sertoli cell tumor or Leydig cell tumor, they will present with androgenic symptoms like virilization. But overlap does occur in these tumors, and non-functioning tumors are also common in this group. And apart from fibroma, all other ovarian sex cord stromal are very uncommon, and the sex cord stromal tumor constitute less than 1% of ovarian tumors. And whenever you are dealing with the case of sex cord stromal tumor, clinical information, age, endocrine manifestation is very important. So these are the examples of sex cord stromal tumor that includes fibroma, fibrosarcoma, thecoma, sclerosing stromal tumor, signet ring stromal tumor, steroid cell tumor, Leydig cell tumor, microcystic stromal tumor, granulosa cell tumor, adult or juvenile type, Sertoli cell tumor with annular tubules, Sertoli Leydig cell tumor. So here most of the tumors are benign, but the malignant tumors are fibrosarcoma, 1/3 of steroid cell tumors, granulosa cell tumor, adult or juvenile type, and also Sertoli Leydig cell tumors are malignant in behavior. Age is has got very significant whenever we are assessing a case, because certain tumors are known to occur in certain age group. Example, juvenile granulosa cell tumor primarily will be seen in less than 20 years age group, and Sertoli Leydig cell tumor is seen in age of menarche or around 25 years. Fibrothecomas and adult granulosa cell tumors are seen in 25 to 50-year age group, and fibromas, steroid cell tumors, and fibrosarcomas are commonly seen after menopause. Few tumors are associated with specific syndrome, so the initial presentation of the tumor may be because of extra ovarian symptoms rather than ovarian tumor itself. Example, fibroma can be seen as Gorlin syndrome associated with basal cell carcinoma, or Meeks syndrome associated with ascites and pleural effusion. Juvenile granulosa cell tumor associated with Olius disease, Sertoli Leydig cell tumor and juvenile granulosa cell tumor can have Dyson mutation. Maffucci syndrome is associated with juvenile granulosa cell tumor, and Peutz-Jeghers syndrome is associated with sex cord tumor with annular tubules and also Sertoli cell tumor. And for the correct diagnosis of any tumors, you have to recognize the full spectrum of every entity. You have to know the morphology of all entity, and the differential diagnosis is very important. You have to keep the differential diagnosis within the category of sex cord stromal tumor and also the tumors which are non-sex cord stromal tumors. And most crucial aspect in correct diagnosis is thorough sampling based on gross morphology. Variable morphologic areas should be sampled thoroughly. And in certain circumstances, ISC will be of very much use. But although it is of helpful in diagnosis, in some cases it will be confusing also. Like few of granulosa cell tumor can show negativity for inhibin ILC. So the most helpful triad in ISC are inhibin and calretinine. Most of these tumors are typically positive, whereas epithelial membrane antigen is a negative marker. So negative EMA will support that it is not a carcinoma, it is a sex-cord stromal tumor. So diffuse staining for EMA in a suspected case of sex-cord stromal tumor will rule out, because EMA should be negative in case of sex-cord stromal tumor. Inhibin is a more specific marker, and FOXL2 and calretinine are more sensitive markers. Other markers which can be positive in most of the cases are steroidogenic factor, that is SF1, WT1, CD56, CD99, and CD10. Leydig and the steroid cell tumors are positive for melan A also. They are specific for these two tumors. And SF1 is reported to stain most of sex-cord stromal tumor. And standard panel for diagnosis of these set of tumors are inhibin, SF1, calretinine, and FOXL2. So this is the table showing the commonly used marker with the pattern of expression. Inhibin is a cytoplasmic marker. Calretinine is a cytoplasmic and nuclear marker. SF1, FOXL2, WT1, and PR are nuclear markers. CD56 is a cytoplasmic marker. CD99 and CD10 are cytoplasmic or membranous marker. Melan A is a cytoplasmic marker. So here the first picture is of alpha inhibin, which is a cytoplasmic marker. Calretinine stains both nucleus and cytoplasm. FOXL2 is a nuclear marker. Signet ring cell tumor will show SF1 positivity, highlighting the signet ring cells. This is WT1, which is showing diffuse positivity for adult granulosa cell tumor. Melan A is a specific marker for steroid cell tumor. Few of Leydig cell tumor also positive for melan A. So as you can see here, the positivity rate of various ISC marker. Inhibin and calretinine show positivity in most of these group of tumors. SF1 shows 100% positivity in all tumors. So it can be used to categorize the tumor as sex-cord stromal tumor. WT1 also positive in most, but not in Sertoli cell tumor. CD99 is also positive in most of the tumors, but they are negative in fibroma and thecoma. FOXL2 also positive in most, but not in Sertoli cell tumor. The most important differential diagnosis in a case of sex-cord stromal tumor is endometrial carcinoma. So endometrial carcinoma can exhibit growth pattern that of Sertoli cell tumor, Sertoli Leydig cell tumor, or granulosa cell tumor. So here in these set of differential diagnosis, EMA will be helpful. So EMA positivity will rule out sex-cord stromal tumor because they are typically negative for EMA, whereas CK can be positive in sex-cord stromal tumor also. So this is the protocol for ovarian tumor. You can take the markers CK7, inhibin, and CD99. CK7 is a marker of epithelial malignancy. Inhibin and CD99 is for sex-cord stromal tumor. So whenever CK7 positivity, you have to rule out epithelial malignancy. Inhibin and CD99 positivity will tell that it is a group of sex-cord stromal tumor. Then you can go ahead with morphological features. You can correlate with, then ultimately diagnosing a specific condition. Germ cell tumor can be diagnosed with CD117 and CD30. So most important differential diagnosis for granulosa cell tumors are all other set of tumors like carcinoma, neuroendocrine tumor, lymphoma, small cell carcinoma, all are DD for granulosa cell tumor because of overlapping morphological features. So for those cases, you can take marker for epithelial malignancy like CK-EMA. EMA will be negative in granulosa cell tumor. LCA will be positive in lymphoma. CD99 is positive in granulosa cell tumor, and small cell carcinoma or carcinoma tumor will show synaptophysin or chromogranin positivity. So what are the pitfalls of ISC? So minority of typical granulosa cell tumor can show negativity for inhibin and also positivity for cytokeratin. Morphologically, area with squamous differentiation rules out sex-caused stromal tumor irrespective of immunohistochemical result. So if there is squamous differentiation on histopathology, it will rule out these group of tumors. So DD in these set of cases is endometrial carcinoma. And steroid cell tumors also has got broad spectrum of differential diagnosis. So as steroid cell tumor is melan A positive, it will be helpful in differentiating from other oxyphilic malignant tumor. And remember, luteinized stromal cells of many ovarian tumor can be inhibin and calretinine positive. So you have to be careful what are the cells of interest, because many epithelial tumors will have stromal luteinized cells which will be showing positivity for inhibin and calretinine. So to summarize, sex-caused cells include granulosa cell and Sertoli cells. Stromal cells include theca cells, fibroblasts, and Leydig cell. Age is very significant for diagnosis. Most crucial aspect is thorough sampling, and standard panel for diagnosis of these group of tumors are inhibin, calretinine, SF1, and FOXL2. And although ISC is of exceedingly helpful investigation, in some cases it will be confusing, and most helpful triad is inhibin, calretinine, and EMA. EMA is typically negative in these set of tumors. These are the references. Thank you.